It is a huge, huge honor today to be podcast interviewing Dr. Edward Feinberg, DMD, in Scarsdale, New York. Is that up by Syracuse or Albany?
We're 17 miles north of New York City.
Oh, okay. So it's really a suburb of New York City.
Yeah,
Okay. Well, you got a long bio, and I want to read every word of it. So first of all, Dr. Edward Feinberg is a graduate of Tufts University. That's in Boston, right?
Correct.
And has practiced dentistry in Scarsdale, New York for more than 35 years. He is the successor to a unique tradition of restorative dentistry and was trained by a master and pioneer in full coverage restorative dentistry, Dr. Elliot Feinberg, who is his father. The techniques used by Dr. Feinberg have documented clinical evidence in a library of 100,000 pictures taken during the past 66 years. Dr. Feinberg is a nationally recognized lecturer and a noted author of scientific and educational articles for dental publications and a textbook, an amazing textbook, the DoubleTilt Precision Attachment Case for Natural Teeth and Implants, available on his website, www.edwardfeinbergdmd.com. He is also a reviewer for the Journal of Oral Implantology. In addition to educational activities, Dr. Feinberg has also served on 4 councils of the American Dental Association and is a past president of the 9th District Dental Association, a component of the New York State Dental Association with 1,600 members. Dr. Feinberg is a recipient of the 9th District Dental Association D. Austin Sniffen Award, the Paul Harris Fellowship Award, and the New York State Pierre Fichard Academy's Award for Distinguished Service. And so the Americans all think that G.V. Black is the father of dentistry, but the French would tell you that 100 years before him was Pierre Fichard. But I want to talk about, I want to read about your book first, because this is really an amazing book. Title of the book is The DoubleTilt Precision Attachment Case for Natural Teeth and Implants, a time-tested alternative to fixed bridge work. And I'm guessing 99% of the dentists listening to this don't even know what a DoubleTilt precision attachment case is, and that's why I'm so honored that you came on the show to talk about it. This book is designed to provide instruction on the philosophical basis for the precision attachment case as well as clinical technique. It presents all of elements that are required for health and longevity and supported with numerous case examples documented with x-rays during the past 64 years. All of the cases were prepared in the same manner, even though different materials were used. This range of documentation is an extreme rarity in the dental profession. What's rarer still is the inclusion of precision attachment cases fabricated on implant abutments during the last 20 years. The ideas outlined in this book should challenge the reader to adopt an entirely new paradigm of thinking. Practitioners and patients alike have been conditioned to think that fixed restorations are always better than removables, and the decision to create fixed bridgework cases often have more to do with emotion than reason. The precision attachment apparatus consists of a male and a female. Any male fits any female with equal precision to 0.0001 tolerance. There is no locking, gripping, or clasping mechanism. Retention is achieved with the double tilt. The case is surveyed with 2 tilts so that the direction of insertion and withdrawal is different from the pull of musculature and gravity. If a stress is applied to the removable, it can move slightly to relieve the stress, but it cannot be dislodged. Destructive forces are dissipated instead of being transferred to the abutment teeth. The result is that the double tilt precision attachment case works on some of the weakest teeth imaginable. Clinical examination and x-ray evaluation of patients during the last 6 decades clearly demonstrate that the double tilt precision attachment cases created according to the procedures outlined in this book generally last longer than the fixed bridgework cases. As a restorative choice, the double tilt precision attachment case is the equal of fixed bridgework on implants, and it should be presented as such. In many cases where implants have a poor prognosis, for example, the double tilt precision attachment case is really the superior treatment option. The double tilt precision attachment case requires minimal maintenance, occasional relines, and no paste is required. It is rare to replace the male component of the attachment even after 2 decades of continuous 24-hour day of function. So after all that, my first question is going to be, what the heck is a double tilt precision attachment for natural teeth and implants? What are you talking about? I know that's what my homies are thinking.
Well, the precision attachment itself is a male and a female, and there's no retentive mechanism at all with it. So The double tilt is the angle of how you take the partial in and out. It's tilted in two directions, and this tilt is different from the pull of the muscles and gravity. So if a stress is applied to the removable, it can move slightly to relieve the stress, but it can't come out. So there's a little trick to teaching patients on how to take these cases in and out. So this whole concept was invented in 1906 by this guy Shays, and nobody listened to him, so he jumped out the window and killed himself.
Are
And
you
then
serious?
I'm serious. Dentistry has a really amazing history.
Where,
And
where,
that,
where was he? Where was he living? What part of the world?
I think he was an American, but I don't know what much about him and his history. But then the real history begins in the early 20s when the Stern Gold Company patented the number 7 attachment, which was basically a male and a female. And the whole concept was applied very early in dentistry's history because my dad got this from his teacher, Dr. I. Franklin Miller. And that's where this came from. So it goes all the way back to then. So the earliest case that was done in our office was done in 1950 by my dad. And that case lasted 31 years. And the males were never changed. So a lot of modern attachment components, you have to keep changing different components like, not vinyl sleeves and things like that. And with this concept, there's practically very little maintenance except occasional relines of the partial. And that's really the only maintenance, in addition to hygiene. But that's really the only maintenance, even after decades of continuous wear, because the patients are instructed to keep the partial in all 24 hours a day and only remove it when they brush their teeth. It's pretty cool.
It is very cool, and I hope to heck someday you create an online CE course on this so everybody listening can see it. On Dental Town, we put up 350 courses, and they've been viewed over 500,000 times from every single country on earth. And looking at all the pictures in your book and all this, listening to it on a podcast is good. But I think seeing an online CE course, it would be better. And I think reading your book would be the best. How much is your book on your website?
It's around 200, I think 225, something like that. I don't remember the exact fee. Believe it or not, I don't remember.
And what's crazy is they don't blink at buying $250 round trip airline tickets to go to some course. But then when they see a dental book for $250, a lot of them balk at that. And that is absolutely the lowest cost way to learn the most information. And even if you were going to see a course, like I remember before I went and saw Carl Misch, the first thing I did is read his book, A to Z. So, you get the first round in the book, you can go back, whatever, so that when you went to the lecture, you would learn so much. Reading books is still the street smart way to learn the best dentistry. And the most expensive way is flying across these countries and staying in resorts and to go to these institutes.
And also, it takes time to absorb these concepts. You're right, even just attending a course, you wouldn't necessarily get everything all in that course. And the book helps reinforce it and something that you could continually refer to. It's very interesting. My dad, we gave courses here. He gave demonstration courses on patients for 40 years in this office. And I sat in on a lot of the courses that he gave. And, typically he would take a patient and he would prepare teeth for fixed bridge work. That was one of the courses, and show every step on a patient to about 10, 12 doctors in about 7 sessions. And we also gave a precision attachment course and did the same thing. And I was here every day, and I learned something every single time because there was always something that I missed. And I would say to my dad, "Hey, Dad, why didn't you tell me this and such? I'm here every day." And so that's what I got from him. So I know how hard it is to absorb everything, especially when it's a new concept and you're not familiar with it, that it takes time and study in order to really grasp it.
That is so cool. So how many children did your dad have, and how many of them became dentists?
Well, I have one sister who lives in Arizona, and
Oh, really?
but she's not a dentist. Yeah, I was just out there to visit her.
Well, where's she live in Arizona?
She lives in Scottsdale.
Well, next time you come by, you got to tell me. We'll do dinner, or you can come
I
by.
would love to do that. That would be great.
I would love it. And I'm in actual Phoenix, but everybody down here calls it Ahwatukee, because it was annexed by Phoenix. So when they annexed Ahwatukee, so it's the southernmost part. So when you go to the airport, there's a big South Mountain Preserve south of it, and Ahwatukee is the section of Phoenix. It's about 10% of Phoenix south of the mountain, and that's where my dental office is. My home is Ahwatukee, but yeah. And if you're ever doing dentistry on your sister, but you just need something, like you do it all, or whatever, or you need a dental office, or you want to adjust something, you come by. A lot of dentists say, but I'm not licensed in Arizona. And I tell them, these laws are just suggestions. They're not real. They're just suggestions. But anyway, so what do you think the state is of removable? Do you think because of implants, do you see removal declining? How has implants changed precision attachments, removables in the last in your career?
Well, I think it's a misconception to think that implants can do everything or any one particular treatment option can do everything. I think there are many places where you can't put implants in, and patients who have all the financial means can't have implants if there's not enough bone to put good implants in. And I feel strongly that if you can't put good implants in, they shouldn't be done. So the precision attachment case gives those patients an option to have the full arch reconstruction without putting implants in areas where they're likely to fail. And so I've been using implants with precision attachment case, and I think it's a great combination because by doing that, I avoid all the bad anatomy. I don't have to get involved with sinus lift surgery. And the most predictable place to place implants is in the anterior region of the mouth, usually. And the patients can bite into anything because they have fixed bridgework in the front. So there's also no anterior, posterior tipping forces that's common with overdentures. I think too, with removables, most of the concept comes from dentures. And when they do implants, the whole concept is screwing a denture in, where really implants, it's more akin to fixed bridgework and fixed bridgework procedures. So I don't view the implant abutments as being different from the natural tooth abutments, or they should be treated differently. Because in a lot of cases, the implant abutments are actually stronger than the natural tooth abutments that support precision attachment cases for decades.
I always also think that one of the errors that the young dentists have that they slowly lose over 20, 30 years is they think treatment planning a removable would be crazy because they're thinking for themselves they would want all fixed. And they think that the consumer, the patient, the customer would not want anything removable. But the truth of the matter is I'm out here in Phoenix with a lot of retirees. I can't tell you how many people who have full dentures in my practice come in, and when you talk about implants, they say, well, I don't have any problems with my denture. Or they'll have partials, say, well, does it bother you that your partials come in or out? And they're like, no. So I think there seems to be a young dentist bias to treatment plan all fixed because in their own noodle, in their own mouth, in their own walnut, they're thinking, I wouldn't want removable. What do you think of the patient satisfaction of removable?
Well, the precision attachment case you can't compare to any other kind of removable, and it's a very high satisfaction rate. I think when you present all the facts to a patient and you let them choose, you'd be surprised. A lot of them choose the removable. And what I always do is because if a patient never wore a removable before, you don't want to just start out and make them a permanent case without them experiencing what a removable is like. So I will always incorporate some kind of temporary removable in the treatment plan so that, let's say, I've had a couple of patients who said, you know what, I don't like the idea of a removable and I'd like to change the treatment plan. I could do that. So everything is step by step all down the line so that I'm not going to have an unhappy patient or somebody who had unrealistic expectations about what a removable is. But the best removable there is the precision attachment partial denture. That's the double tilt precision attachment case.
Oh,
Really.
you're just saying that because that's your book.
Well, you see, the problem is that the clasps and all of the other types of attachments are usually locking mechanisms that grip the abutments, and these pass along destructive forces. See, teeth can take vertical forces, but they can't take lateral forces, so they function laterally. Whereas the double tilt precision attachment case first functions vertically, and the forces are of the destructive forces are dissipated. So I could show so many cases where you have very weak natural tooth abutments, and it supported this removable partial denture for many years. And you ask yourself, how could this possibly work? And yet it does. And I think that has a great deal to do with it.
How could I bribe you to make an online CE course on this for dental
Oh, you
talents?
don't have to bribe me. I'd be glad to do it. I'd be
I'll
happy
give
to
you my
do it.
son if that's what it takes. Ryan's sitting right here next to me. I'll
That's
give.
great.
I'll.
I worked with my dad, and it was a fabulous relation. We had a great relationship. We practiced. I've been actually working in this office since I'm 16, and my dad and
Wow,
I practiced together as dentists for 23 years. So I think it's great that you're with your son,
Ryan, you got to
and I
stay
think
with me
it's
20 at
special.
least 23 years. You got to beat Edward here. You can't let him win the battle at Ryan. You got to beat him. Yeah, I think in fact we could also do something. I think it'd be almost like an introductory to your book. I hope this is an introductory for everyone listening, an introductory to your book because this is a great service. And also, like General Motors has a high end Cadillac, and you save a little money, get a Buick, a little more money, Olds, a little more a Pontiac, save the most Chevy. Remove these double tilt precision attachment removable cases are significantly less than going to Clear Choice and paying $25,000 an arch for all on four, correct?
That's absolutely correct. That's correct. And some things about some of the all on four cases that worry me is that some of the implants are put in on an angle and are being asked to absorb all these forces, and how that's going to hold over time and what percentage will hold up over time, I don't know. Because, I've had a chance to see how these cases hold up over decades. And the precision attachment cases hold up on the weakest teeth you could possibly imagine over decades. So that concerns me. We've been doing implants here since the early 80s, and I've seen them fail even after 20 years. So I've seen cases last for 20 years, and that was it. The implants went. Part of it was because of the type of implants that they used in that era. But we don't know how things are going to work out, and a lot of what's being done has to really conform to good principles of engineering because there's so many things that we don't know the answer to. So putting implants in that aren't long enough, that's the same thing as if you're building a building and you don't have the foundation that's strong enough to support the building. That's exactly the same. So that's what worries me. So if I could put three good implants in the anterior region and make a precision attachment case, I know that from an engineering standpoint, that's a really sound case that's going to last a long time.
And how much, I think, if you ask any economist, say, what's the number one variable to trade, they would say price. You might say the best car in the world is a Mercedes, but they'll tell you, you're going to sell a lot more Ford Tauruses than Mercedes just because of price. What is the price difference between like a $25,000 all on four versus what you just said, three implants and a fixed precision attachment partial to fixed anterior? About what price range would that be?
Well, that would be less. I mean, I'd
But
say
what?
we're doing them here in conjunction with our surgeons for like about 20,000 for to restore a whole arch. But a lot of it depends on what materials you're using, what your overhead is. So the price by itself is can vary. It's the quality of how it's done that's really important. And how likely it is to last. Like we're judged by patients. Sometimes they want to compare us all. We're all doing the same thing, and they want to compare us all according to price. There's no doubt about that. But really, they don't find out how good you are until at least 5 years. I mean, anything less than that doesn't mean anything, I think. So if, let's say, I have a patient, and I have patients where these precision attachment cases were done, and they have that case 30 years. That's the best investment that patient ever made, and by far the cheapest. So I think that's an important consideration that patients should be thinking about. How long is this going to last? What is you can't guarantee anything, but what percentage lasts? See, I could show those cases on some of the really weakest teeth ever imaginable and show how they lasted over 30 years with minimal changes in the x-rays. That's really unusual. So I know when I present something to a patient, I'm really standing on solid ground, with a real track record behind me.
And when we're talking about solid ground, in your experience of decades and 100,000 photos, do you think a lot of implants are failing more from engineering principles or from peri-implantitis?
Oh, I think engineering principles. People are just sticking them in all over the place, and they're not correcting the things that are wrong. So, one of the signatures of a piecemeal approach to dentistry is the single tooth implant, because I think a lot of dentists don't have confidence in their crown and bridge skills, but they have a great deal of confidence in their implant skills. But when they put these implants in, they're ignoring a lot of what's going on around this implant. You go to any implant lecture, you'll see that, and you'll see everything falling apart around this single tooth implant. I've seen implants shear off below the bone level because destructive forces were being applied to them. I've seen other cases where the screws loosen all the time because lateral and destructive forces are continually being applied to these implants, and that's why they loosen up. That's the reason. So I think that a huge reason for failure is engineering considerations. You have to correct the bite. You have to make sure there's no neuromuscular problems that are going to interfere with the success of your case. Otherwise, you're just going to have major problems.
You remind me so much of Carl Misch because Carl Misch's story was he started out as a prosthodontist making full dentures, and he was seeing the other people doing these implant-supported dentures, and he saw the implants shearing off, and he said, These guys don't know anything about forces. They don't know anything about removable. They just think if they stick titanium in the jaw, they can put anything on top of it. And he credits a lot of his success was by mastering removable dentures first and then adding implants to his curriculum instead of not understanding removable and just going into fixed implants.
I think that's absolutely correct. I think that a big problem is that people think that implants can solve every restorative problem, that they're panaceas. But there really is no such thing as a panacea, and there's no such thing as one size fits all. And you really have to look at everything closely. So I think if you can't put good long implants in, they shouldn't be done. So when I send patients to my surgeon to be evaluated, I want to know if they could put good long ones in, and if they can't, then I don't want them done. I know they're going to fail. I've seen a lot of implant failures, and most of them are for those reasons.
For someone who's been around the block with your father, a long career, it seems like the human condition is extremist. Like they'll start learning implants, so they'll never do a 3-unit bridge again. Do you think the 3-unit bridge is dead because there's implants, or do you think sometimes a 3-unit bridge is a better scenario?
Oh, I think without question the 3-unit bridge is a better scenario, because what I just mentioned about the piecemeal approach to dentistry, where somebody puts an implant in and the teeth all around the implant are failing, or they have fillings and big crowns in them. If you know how to do good crown and bridge, you could do something good for the whole area with a fixed bridge. And that's sound, and that's going to solve that patient's problem for the whole area. Whereas a single tooth implant only fills a space. That's all it does, and doesn't address any of the other problems around it. And so, I had one patient where he was seeing a dentist who believed in the implant theory of, when the teeth go, we'll just put an implant in there, and that's kind of like supervised neglect. And that assumes that that patient's always going to be a candidate for implants. And then this patient is now 90 years old and can't have any more implants. What happens to that patient? That's not a fair way of looking at things. So I think that's a bad concept or a bad model. There is no such thing as one size fits all. I think the perfect place for a single tooth implant is if you have a virginal mouth where the teeth are sound, and you don't want to cut them down to make fixed bridge work. But if they already have crowns and big fillings and are going to need crowns, it doesn't make sense to do implants. That patient would be better off with a fixed bridge.
I want you to weigh in on this, even though you'll be biased towards a dentist, but I have a feeling you won't be biased because you've been around the block. I have talked to more than one ear, nose, and throat or rhinologist that's telling me about this, this implant sinus lift nightmare. And he's saying, I don't get it. All that dentist had to do, you already had two teeth there. All you had to do is put that missing tooth hooked onto those two adjacent teeth. But they went in and they buried into my sinus and packed it full of cow bone and titanium, and then they're telling me that the complications. Do you think that dentists are emotionally biased to save enamel because we're dentists and we don't give a crap about what the ear, nose, and throat or the rhinologist has to deal with, whereas the ear, nose, and throat might be more emotionally biased to leave the sinus alone and you go, work on other teeth? Do you think we're biased towards blow up the sinus and save the teeth because we're dentists? And the ENTs are biased at stay out of my sinus because I'm a rhinologist and you're a dentist?
I don't know if it's that. I think that people end up focusing on some areas where they excel. Like, for example, some people, if they could do great implants, the answer to everything becomes implants. And the bonding people are that way. The answer, they could do great bonding. The answer to everything is bonding. And the truth is that they all have limitations. And the better you are, see, if you could do good fixed bridge work, if you could do good implants, if you could do a good precision attachment case, you could do good bonding, you could pick what's right for each individual patient. Like, for example, my mother gets sinus type migraine headaches. I don't want to do sinus lift surgery on her. She's already got lots of troubles. So I would try to avoid that. I think too many dentists become emotional, and put themselves, oh, I wouldn't like to wear a removable, so therefore I don't want to recommend a removable for my patient, or I don't have confidence in my removable because most patients don't like them because they move. And then they end up sticking their neck out to do these treatments, which can be disasters or have disastrous results. So I think you really have to really sit down and look at everything. And if you have that patient who wants it and they're willing to go through all this stuff, I have no problem with that. It is their choice, and my job is to give them choices and then help them pick what choice is best for them. So I want them to have all the facts.
My favorite Aristotle quote was, "It is the mark of an educated mind to be able to entertain a thought without accepting it. And the condition of the human is an extremist. And everyone, as they get older and wiser, become a moderate. Like see either, no 3-unit bridge, all implants, or just I still don't understand when these dentists advertise on their website they're metal free. I mean, what does that even mean that you have a metal free practice? I mean, do you fly in metal free airplanes? Do you drive metal free cars? Is your house void of metal? Why is metal all of a sudden bad? And then you look in their office and they're using metal anyway. But everything's all good. I want to open up a whole nother can of worms. Mini implants. Some people are using mini implants for removable attachments. What are your thoughts on that? Someone has a loose denture. They're putting 4 or 5 minis down there with O-rings. What do you think of minis? Do you think there's a place for them?
I don't know. I think it's experimental. I wouldn't stick my neck out to do things like that. I really would rather do something I could hang my hat on that has a track record and let other people do the experimentation with these things. So that's my feeling.
Okay, I want to ask another can of worms because you said the word neuromuscular twice. There are 2 camps in occlusion. One is Dawson, Pankey, CR. There's another camp, neuromuscular. And a very specific question that we get to this podcast is, I'm out of school. I want to learn more about occlusion. and these institutes are expensive, like LVI and Coyce and Spear and Scottsdale Center. They're all expensive, but there's clearly neuromuscular occlusion camps, and there's CR, Panky Dawson. Do you have how would you answer that question? She can't afford to take both of these courses. Would you ever start CR or neuromuscular? And the only reason I ask you is because you've used the word neuromuscular twice.
Well, I have to say, I'm not an expert in all those areas. However, if you have a new patient and they come to you and I take a full series of x-rays and study models, and I look at the study models, and if I see the midlines don't line up, if I see there's abnormal wear, if I see evidence of something going on, I want to know what caused that patient's problem. So I put them very often on a diagnostic appliance, which is nothing more than a Hawley bite plate, with instructions that they are to wear it 24 hours a day. Eat with it, sleep with it, because every time the teeth come together, the teeth send a message to the brain where the jaw should go. And if that's not in harmony with the muscles, that's where all the destruction happens. So the purpose of putting the diagnostic appliance is to eliminate those messages and let the muscles relax and tell the jaw where to go. So after 4 to 6 weeks, I examine the patient, and if the teeth come together in a different position, then I know that the bite where the patient has is different from where the muscles are comfortable. Then I can take some kind of a wax bite to put the models together and analyze what would have to be done to correct that patient's problem so that you eliminate all of the bruxism and the grinding and all of the destruction that's occurring. So, that's really how I do it. I got that from my father, who got this from this Dr. Berliner, who in the 60s wrote a whole textbook on this subject. So I still think there's a lot that we really don't know about occlusion. And when I restore a patient, I always think in terms of restoring them to an ideal occlusal plane to eliminate a lot of the lateral destructive forces. So that's how I do it.
So your book is 220 pages. How long do you think it would take a dentist to read that and comprehend that and get it? I mean, is that a weekend read? Is that a how many hours do you think? Like, I actually was curious about my book. I sat down and read my book. I made an audiobook of it. It's 5.5 hours. How long do you think it would take to read that your book?
I don't know. It depends on the level of knowledge that the dentist has. And
Good
then
answer.
also, yeah, I really don't know. So, also, too, there are a lot of new concepts that would be new to most practitioners. And that sometimes takes time to absorb. You might have to read it more than once. I mean, I wrote this very carefully, so there's a lot in it. And everything that I said in it has meaning and is important. And I know, even from attending lectures and from, reading myself, that very often you miss things on the first go around, or maybe you're not attuned to what you're really reading, so it doesn't register. And you have to go back and reread it in order to really fully comprehend it. Once you start doing a case, then some of this stuff takes on new meaning because you're more familiar with it.
So what advice would you give? The bottom line is you're on a podcast right now, and only 5% of Americans have ever listened to a podcast, and all the data shows they're all under 30. And so you're talking to a lot of people. Probably 20% are probably juniors and seniors in dental school, and the other 80% are probably been out of school 5 years. What advice would you give them? They're because it's a very different environment than when you got out of school. Or think of when your father got out of dental school, they didn't even have dental insurance. I think the first dental insurance was 1948. When did your father start practicing?
He started practicing in 1948.
Okay, so that was the first one. It was a New Jersey Longshore Islanders dental insurance. So even when that came out, 99% of Americans didn't have it. And now it's then insurance became massive fee for service. When you and I got out of school, now it's all changed to PPO. What advice would you give them? Do you think you can do this level of dentistry that you're talking about in a PPO practice?
Well, I think it can be done. I don't believe in that insurance should be dictating what we do. It's not insurance, even. In dentistry, it's payment assistance. And I think that's what the big problem is. It's like a big deception. And the patients are all fooled into thinking that they have something that they really don't have. But I think you have to sit down and talk to people. And you're not going to reach everybody, but you can reach some people who appreciate, the big term picture and what they're going to get. And this, let's face it, you could live with dentures, but is that good quality of life? I said the best quality of life is that you hold on to your teeth. Everything about what you do, you smile, you eat 24 hours a day. That's the best investment that you could make in yourself. We have to try to communicate that to people. So I think they'll be happy to pay the extra cost in order to have the better work. There are lots of people who want good quality work, and we're here to give it to them.
So, what would you say to someone they're graduating and they say, Dr. Feinberg, to graduate from dental school, we only had to do 15 units of removable, and I want to learn more about removal from complete to partials to precision attachments. What would you recommend to learn more about removable?
Read my book. Also too, everything, dental school can only give you a very rudimentary foundation. Everything I learned was after dental school, and I had a great mentor. So I would say attach yourself to a good mentor, somebody who's doing really good top quality work in your area, and see if you can befriend them and let them become a mentor to you, somebody you could go to and ask questions of, somebody who will help you, point you on the right direction. That's what I had. And then you are
Are you talking about your
responsible.
father?
My dad, yeah, he was my mentor. Everything I am is because of him. He
That
was a
is so cool.
genius.
That
He
is
was
so
he
cool.
was an absolute genius. You know, as I said, I have 100,000 pictures of cases that go back to 1950. Nobody will ever match the sheer volume and quality of the work that he did in his lifetime. It's a treasure, and I hope that I can go through because I haven't even touched, a quarter of what's there in that collection. All slides, and they held up over all those years. So when I give presentations, I like to show the old with the new because that's what gives validation to this whole approach to dentistry. But I'd say to the young people, you are responsible for your education. And what you got was a rudimentary foundation. Now it's up to you to continue to educate yourself and become better so that you could become the best person you could possibly be in dentistry.
So you graduated from Tufts in 1977. Tell those, how many years ago was that?
I don't
Uh,
even want to calculate that.
1977. So seven from six is nine, seven from 10, 39 years ago. So you're coming up on your 40th.
I know it's hard. It is so hard to believe. It goes so fast. I
Dude, you
can't
look
even believe it.
amazing. You look younger than I do. I'm my dental school. I graduated in '87, so next year is my 30th, and you look younger than I do. Um, um, but tell these dental students because they might not believe this, but what percent of everything you learned in dental school 40 years ago is basically extinct?
I'd say most of it, like 90%. But they
Yeah,
gave you see, but that's all true in all professions. I think all they can do is give you a very rudimentary foundation. That's all that could be expected from them. They can't
right.
show you everything. What bothers me about a lot of them is I think they close a lot of minds. And they make people think that their way is the only way and the best way. And very often that's not true at all. They had to show you a way in order that when you got out of school that you would have some proficiency. But that's it. That's all they should be expected to do. So I think they're doing their job. What they should do better is make students understand we gave you a rudimentary foundation. Now go out and take all the courses you can, build your knowledge and skills, and become the best dentist that you can be.
Okay, now you don't make those precision attachment partial dentures. A lab does. Can you help my? Can you share a
Well,
lab that does this?
that is not entirely true. Okay, because I do all my own preparatory work. I pour all my own models, make all my own dies, so that everything that's going to be made on those models, then I could send it to a technician. So I have one guy who does the metal work, and I have one guy who does the porcelain work. And otherwise, I do everything else myself. I even process the teeth on the partial. but you have to
How long
have.
is your presentation on this? If you were just going to rant from A to Z on all your presentation,
Ah,
how long would it be?
it could be hours. It could be
You
hours.
need to do this. You really need to do this. And you know what's really cool about the online CE is when I go to dental schools in Asia and Africa, their textbooks are 20 years old, and those courses on Dental Town are just everything. It's their only way to connect with the most.
I'd love to do it because, I feel very strongly this was given to me. I fell into this. I was born into it. And I feel very strongly that I'm obligated to give this back. And I want to do all of that. So I'd be happy to. Just tell me what I have to do and I'd be glad to.
Well, I'm Howard at dentaltown.com. The person in charge of online C is Howard Goldstein in Bethlehem, Pennsylvania. He's a dentist in Bethlehem, Pennsylvania. And so I'm Howard at dentaltown.com. He's Hogo because we already had one Howard. So Hogo at dentaltown.com is Hogo. How far are you from Bethlehem, Pennsylvania?
Probably not that far.
Yeah. But
I've
anyway,
been all over Pennsylvania. I gave all these courses for the University of Pittsburgh in their outreach continuing education program. So I've been all over Pennsylvania.
that's a great dental school there. I did Carl Mish's curriculum at the University of Pittsburgh, but my fondest memory is that it was like 7 3-day weekends, but the last 3-day weekend there, Kiss was playing. So all of us old fart dental students, dental dentists went and saw Kiss. I think that was one of the most fun nights I ever had. And then for some reason I couldn't go to class for an hour late the next morning. I don't know why that was, and that's a joke. But so you talked about labs. What is there a brand name of these precision attachments that you use? I mean,
Well, there's only one male female. See, in my book, the original number seven attachment is no longer made. But it's the concept that's important because we've made them with different versions of male female attachments. So the one that's the only one that's around is the Sterngold latch attachment. And the latch doesn't really work, which is good because the latch consisted of a little semicircular ball in the female and a depression in the male. And I used to wipe away the little ball with a little inverted cone burr because I did not want any kind of retention. But it doesn't function in a very short period of time, so now I don't bother doing that. But it's a simple male and a female, then that's it. The thing is that if you are working with a technician, most technicians only know how to do one tilt. So if you only do one tilt, then the partial is likely to come out all the time. And then you have to put some kind of either redo the whole case or some kind of lingual arms or whatever on it, and that defeats the whole purpose of the precision attachment case because you're applying lateral forces to the abutment teeth. So they have to know how to do a double tilt. So they should check the wax ups on the surveyor and check everything on the surveyor before anything is made, so that they make sure that the double tilt is incorporated into the case. Because you really won't find out until after the patient is wearing it, and then you have a problem.
so you went to Tufts in Boston, and Sterngold is in Attleboro, Massachusetts. Was that a suburb of Boston? Did you ever go to Sterngold? Did you ever work with those guys directly, or?
Oh, I call them up all the time. I've actually never been to their place.
But is
I
it
never
outside of
have.
Boston?
I
Is
think
that a
it's not too far. It's not too far from Boston,
huh?
but
But
I've never actually been there.
so that's not only the recommended male female. You're basically saying it's really the only one.
Yeah, it's the only one I know of because it's the concept that's important, and I don't know anybody else who makes anything like that.
Huh? That is so interesting. So what other advice do you recommend on removable in general? Any other removable advice? Because the bottom line is, if you go to the ADA convention, there's just a ton of courses on CAD CAM, implants, cosmetic dentistry. The removable section isn't the hot and sexy section. They don't seem to be a lot of good tips on that. What other good information could you share with removable in general?
Well, I think these are the best cases. The reason why this is called a precision attachment is you have to have a precision mindset. Every step along the way has to be done with precision. So this is real precision dentistry, which is really cool. I mean, if you are a really meticulous, uh, precision-oriented dentist, somebody who is wants to do real good quality work, then this is the kind of case that's going to make you really happy or really challenging. Most people are not really being taught how to have that kind of mindset. So they want to put something in a hurry, make it look white, make a quick buck, and the patient's out the door and not worrying about what happens down the road to these patients. But when you think about what we're asking dentistry to do, precision becomes very important, especially when you realize that the best we can really work at is the tenth of a millimeter level, and bacteria are nanometers. And we're expecting our dentistry to function 24 hours a day underwater in an environment loaded with bacteria and under forces. And that we get anything to work is a miracle. So the precision approach is critical to a high percentage of success. Very, very critical. So most people aren't being taught that. I think in the past they were taught more with different techniques like maybe gold foil to have precision attachment and to have a precision mindset. So they do everything meticulously, step by step, and that was important. I think today the way things are being done, it looks like it's less important. So the people who are going to be most interested in this kind of a case are people who want to do high quality, high precision work.
Now, is there a any demographics? I mean, are people who getting this? Is there a certain age range where they most fit? Are they more likely to be grandma or grandpa? Do you see any demographics? What demographics do you see
Well,
in
my
getting
patients are
this?
mostly older because, in order to make a removable, you have to have, missing teeth where you can't make fixed bridge work. But I have younger people now who lost a lot of teeth who are good, great candidates for this. So it really is less age dependent. I've made precision attachment cases on implants for 90-year-olds. Okay, because so age is not really a factor in this at all. And that gives me tremendous advantage because I can make this case on 3 implants, and I put them in the easiest areas where they're most likely to have success, and I can make that case. And though they're great cases, those patients can eat anything, bite into anything, and don't have to worry about we're using paste or anything like that.
If I ever live to be 90, the only thing I'd want on my 90th birthday is for someone who loves me to come up and hit me over the head with a shovel. And
Yes,
you're
but
saying you have
when
patience that
you
still.
talk to people who are 90, they don't think that way. I have patients who are in their 90s who are skiing, and they want to live and they want to have a good quality of life. So, I mean, I think everything is relative, and I think like maybe 90 is the new 40. Wouldn't that be great?
Well, I'm in Phoenix and there's all these retirees and it blows my mind. I get pretty. I'm 53, fat jogger, and I have many patients that pass me out on the road that are between 80 and 90. This morning I got passed by one of my patients who's 86 years old, and he always pinches my gut when he passes me. He always reaches over and grabs my belly. And it is true. It is amazing how they are breaking so many age barriers. Would you say that the teeth and implants last longer with removable because they can get in there and clean better than if it was all fixed and nailed down? And do you think the implants and teeth last longer, like an all on four? Do you think it would last longer if it came in and out of your mouth versus was screwed down, fixed?
Well,
Because
I can't comment on how all on fours are going to hold up after
well,
20
yeah,
years.
I
Yeah,
should
that
have
I
said
can't
that. I should have
comment,
said
but I
so.
can
Let's
comment
fixed
that,
versus fixed
it,
and over removal.
okay, yeah. I This is what I can comment on. one of the things that we do is we check our patients at our hygiene visits. And if you are really paying attention year after year after year, you will see that the cases that last the longest are the precision attachment cases. And I've had patients where, maybe one arch is fixed bridge work and another arch is precision attachment case. And the fixed bridge work will have to be replaced long before the precision attachment case has to be replaced. And I think that's pretty amazing. But that's typically what you see. That's the fixed bridge work lasts far longer. I mean, the precision attachment cases last far longer than the fixed bridge work cases. Maybe because the loads are dissipated better with the precision attachment case. Maybe weak abutments are not really part of the case or used in such a way that they're not part of the case for the precision attachment case. Whereas with fixed bridge work, they have to support the bridge work.
So you went to Tufts in Boston. Massachusetts has 3 dental schools: Tufts, Boston, and Harvard School of Dentistry. That's right. Am I right? 3
Right.
dental schools in Boston.
Uh-huh.
So I want you to go on record and rank those 3 dental schools first, second, and third. That means
Oh,
you're gonna
both of them?
no all
Well,
3. Which one's
I
the
only
best?
have
Tufts,
experience.
Boston.
You know what? There is
I'm
no
just
one
trying to
single.
get you in
Yeah,
trouble.
there's no one single best. I think that's as I said, they can only give you rudimentary foundation. So I think they're all basically the same, except certain schools are a little bit better in some areas than other areas. For example, like BU, they excelled in endo because of Herb Schilder, and I
That's
went and
right.
took all those courses, and he was an amazing teacher. I learned a lot from him. So, if I'm sure this is true in most of the fields where there is somebody really special at one of the schools, and they have a program in a particular area which is unequaled by all the other schools. So in that area, that school would be the best. But I don't think any school is necessarily any better than any other. I think
Well,
that
of those, well, let me ask this question: of the 60, what are we up to? 64 dental schools now, or
well, we're
uh,
getting we're getting a new one here in my area. The Turo School of Dentistry is only maybe 5 miles from here.
what's it called? Toro, T-O-R-A.
Touro, and they're going to accept their first class this year.
Well,
That's really, I never in a million years would have thought that could ever happen, but it
are
did.
you gonna get involved with the
Oh,
school?
absolutely. Yes. I'd love
So
to.
it's Toura,
Touro. They actually have
Touro Dental School.
they actually have Touro College has schools all over the country, and they wanted a dental school, so now they have one.
Now, what is the mother school? Is it an osteopath school or an MD
It's
school?
New York Medical College is part of Touro College, and that's here in this area.
Nice. So, are you excited about that, or do you think it's a bad idea?
I think it's a good idea. It can Dental schools can be a bad idea in that if they take patients away from the practitioners in that area, or they don't have a good relationship with the people in that area. They really reached out to us, so I think we're going to have a great relationship. I think it's going to be a win for everybody, and so I'm looking forward to it.
So, I think, yeah. So, of all the dental schools, how many of them do you think right now teach your double tilt precision attachment technology?
Zero. I think almost nobody knows anything about it, which astounds me because it comes from the very roots of the profession. And I think, when I went to dental school, we had one precision attachment in our kit, and we were never shown how to use it. So,
Do you think it's because in all older dentists always complain, well, they didn't teach this in dental school, they didn't teach, and I'm like, come on, dude, they take 100 kids off the street, and in 4 years they got to give them a license to treat the general public. They can't teach them everything.
no, they
Do
can't, and they're
do
not ready to absorb that.
right,
At
right,
that, they have to get their feet wet. They have to do conventional removables before they can jump into doing precision attachment cases. So they're not wrong.
right,
But
right.
I think unfortunately, it's been neglected. This area has been neglected, and very few people know anything about it. And these are the best cases, and they come from the very roots of the profession. That's why I had to write the book. If I didn't write the book, all this would go by the wayside, and I think that would be a tragedy.
Yeah, well, I'm just honored that you would be on my show today. So you're telling thousands about it today, and I really hope you do an exhaustive online C course. I think it'd be great marketing for the book because I think when they hear the podcast, I think that's going to make some buy the book. But I think if they see it, because I think a lot of people driving to work right now in their car might not be seeing exactly what you're talking about. I think you do an online C course, and everybody that takes it will tell you their name and number and email, and hopefully, I'm sure if you keep referencing your book enough times, the deal they'll get your book because I think it's a great service. I do believe that as you get older, you become more moderate. You're not gonna if your only tool is a hammer, everything looks like a nail. That's where implants are going. You know, an implant will fix anything, and it's just not truth. And there's still a big piece of the pie, a big part of the puzzle to help all your patients is still going to involve removable, gold, amalgam, glass ionomer. I mean, if the average dentist has 2,000 patients, you need a portfolio of treatment plans, not just three things in your toolbox. I think
Absolutely correct.
But I think you're an amazing man. I think you have an amazing book. You're just a neat guy. That's so cool how you idolize your father and he was your mentor. That is just so damn cool. That was a big healing thing for me. My dad was my idol and on the business side of things, and he had 9 restaurants. So when he died, I cried for half a year and it felt like someone was standing on my chest. And then one day I woke up and I thought to myself, well, why am I making this all about me and crying about my loss? I got 4 little babies back there. I need to quit thinking about my loss and start turning around and looking at those 4 boys and trying to get it so when I pass, they think the same way of me as I thought of my old man. And that was the only way I got through it. How did you deal when your dad passed?
It was hard, being here. He worked almost until he passed, until 2 months before he was here in the office. And it was difficult because, I had somebody to talk to. And now here I was all alone, and it was difficult. I also had a lot of problems to deal with that were kind of dumped in my lap with his passing. And so it was a very, very difficult time for me. But I miss him a lot, he was really a genius. I really grasped right away that he was something special, that no one, as I said, nobody will ever match what he did. And he practiced in a different era where the things that he did, there were no implants, there were no things like that. And the things that he did were simply mind-boggling, real miracles. And I was blown away by it. And I think he was blown away by it too. And so all these things really came from him. He was influenced by his teacher, who also was really an amazing human being, amazing person.
Is that the one who jumped out of the window?
No, that was Dr. I. Franklin Miller, was my dad's mentor.
I
And
bring him out. Who was the one who jumped out of the window? What was his name?
his name was Shays, Chayes.
Chayes.
Yes,
And what was he? And what did you credit him with?
He's developed the double tilt concept with
He
the male and
developed this.
female. Yes,
So
it
if I
was
read
his
this book,
idea.
if I read this book, will it increase my chance that someday I'll jump out the window? I'm not worried. I only live in a
I don't know
two-story
why he
house.
jumped out the window, but I always say in my lectures nobody would listen to him, so he jumped out the window.
Well, that's why I only live in a two-story house. So if I jump out the window, I'll just sprain an ankle. I won't. I won't go splat. But hey, man, seriously, thanks so much for being on my show. Thank you for your commitment to all this work that started. What year did you say was Shays started this?
1906. That's
1906.
when you
That is.
think about this, it's mind-boggling that something came from that era when they barely even had anesthesia.
And when was the germ theory? When did they even discover germs?
That was in the 1800s. It wasn't maybe, what, 50 years earlier?
Yeah.
Um, so dentistry really came a long way in a very short period of time. It has a really fabulous history.
Yeah, and so did the American economy. I mean, that and just a little time out of nowhere. I mean, it was the steam engine, the light bulb, the electric motor. I mean, it was just all this massive stuff right out. I always wonder if the next century will be like the last century.
Well, I think a lot of it depends on people's attitudes. I don't like some of the things that I see, and I hope I can make a difference and change them. I think that's the most important thing, the mindset and the attitudes of people. And one of the reasons why we're having all these problems is because of that. I think there's no question about that. There's other factors too, like they sent all the jobs overseas. If we can get that back, I think we could have what we once had.
All right. Well, on that note, we're out of time. It's an hour. Thank you again for all that you've done for your patients, all that you've done for dentistry, your D. Austin Sniffen Award, your Paul Harris Fellowship Award, getting involved, the Pierre Fauchard Academy, getting involved with this new dental school. Seriously, thank you so much for spending an hour with me today. I really, really appreciate it. And I hope these dentists listening can see your online CE course someday, because you can see it on your, now it's even on your iPhone. Most of these people are watching, so here's the iPhone. So you just hit the CE deal, and there's 350 courses, and they're sitting there listening to these courses. And the thing that us older guys don't realize is, you think of a big screen TV, or you go to a lecture and you have that big PowerPoint, that big screen up there. Well, you take your iPhone and you hold it up in front of that screen, and you pull the iPhone back until you can no longer see the screen at the dental convention or your big screen TV. And it's basically just 4 or 5 inches in front of your face. And now what's really exciting is they just released 2 weeks ago the Oculus virtual reality goggles. So it's not going to be long before on Dentaltown Online CE, you'll just put on those goggles and you won't see anything but your presentation. Because when you're looking at the TV, so much of your peripheral vision is the ceiling, the wall, the carpet, the cat on the floor. You're seeing all this other stuff. But as you pull it closer and closer to the eye, that's what Google's been saying. Google's been saying it's not how big is your screen, it's how close is it to your eye. And so this online CE is really going to be a game changer from here to Kathmandu. I've watched dentists taking these courses in Tanzania, Ethiopia, South Africa, Namibia. They love it. They just absolutely love it. And they even tell you they could never afford to fly to Europe or the United States to see some of these courses. So look forward to your online CE course, and thanks for all that you've done.
Thank you so much too. I really enjoyed this. I really did, and I will definitely make that course for you. And I hope that we get to meet sometime.
Well, next time you visit your sister in Scottsdale, you got to come see me. I'm in the poor part of town, Phoenix.
I will be there. My sister's not too far from you. I know she lives close to the airport, so it's not too far from you.
I'm 11 minutes from the airport.
So is my sister, so she's got to be very close to you.
Right on. I can't wait to have dinner with all of you.
Great, same here. Thank you.
Okay, bye-bye.